So this was a multicentre retrospective study with the aim to assess the real-world efficacy and safety of teclistamab in patients with relapsed refractory multiple myeloma. So we included a total of 106 patients from 5 U.S. academic institutions who received standard of care teclistamab. So teclistamab is a BCMA targeting bispecific antibody that was approved by the FDA in October of 2022 for the treatment of relapsed refractory multiple myeloma based on the results of the phase 2 MajesTEC-1 trial. So like many other landmark registration trials, the MajesTEC-1 had strict eligibility criteria and excluded patients with significant comorbidities, organ dysfunctions, severe cytopenias, and prior exposure to anti-BCMA therapy and other high-risk disease features, which we typically see in routine clinical practice. So for this reason, we felt it was important to investigate the real-world outcomes of teclistamab in high-risk patients who would have been considered ineligible for the trial. So among the 106 patients included in our study, 83% would have not met the inclusion criteria for the trial. Most common reasons for trial exclusion were receipt of prior BCMA-directed therapy in about half of our patients, severe baseline cytopenias in about 1/3 of our patients, poor ECOG performance status, again, in about 1/3 of our patients, and then renal dysfunction in around 13% of our patients. Other reasons were presence of liver, cardiac dysfunction, plasma cell leukemia, and central nervous system involvement in lower rates. And notably, 41% of the patients met 2 or more of the exclusion criteria. We included a high proportion of patients with high-risk features. 64% of our patients had penta-class refractory disease, 59 had high-risk cytogenetics, and 42 had extramedullary disease. And also 32% were older than the age of 70, and also approximately 1/3 of our patients were minority patients. All these high-risk features were seen much higher proportions in our population compared to the MajesTEC-1 trial population. So in terms of efficacy, overall teclistamab appeared well tolerated and relatively effective in a real-world heavily pretreated patient cohort. The overall response rate was 66%, and that was comparable to the 63% seen in the MajesTEC-1 trial. The overall response in patients with high-risk cytogenetics, penta-refractory disease, and patients older than the age of 70 remained high and ranged between 60 and 70%. However, patients with extramedullary disease had overall worse overall response rate, and it was about 47%. So in further analysis that we did, we found that factors associated with worse overall response were presence of extramedullary disease, ECOG performance status of 2 or more, and receipt of more than 4 prior lines of therapy. In routine clinical practice, a significant number of patients have previously received and failed other BCMA-directed therapies. The overall response in these patients in our study was comparable to the response in the overall study population. The most common prior BCMA-directed therapy in our patients was CAR T-cell therapy. Thus, for us, it was really encouraging to see that we can give teclistamab successfully after failure of CAR T. Despite of our patients achieving similar response compared to the MajesTEC-1 trial, the MajesTEC-1 had higher rates of complete or better response and higher median PFS, probably reflecting the greater severity of illness in our patient population. From a safety perspective now, we did not see any new red flags or excessive toxicities with teclistamab. So the primary side effects associated with teclistamab are cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome, or ICANS. So the rates of these two in our study were comparable to those seen in the MajesTEC-1 trial. And importantly, the rates of severe cytokine release syndrome and neurotoxicity in our population remained low at 1% and 3% respectively. In addition, all the CRS and ICANS events, except one, occurred with the step-up doses or the first full dose in the inpatient hospital stay and not in the outpatient setting, which was very encouraging. Around 31% of our patients developed infection, which was much lower than the 76% seen in the MajesTEC 1 trial. This was most likely attributed to the shorter follow-up seen in our study compared to the MajesTEC 1 trial. So our study's follow-up was 3.8 months versus 14 months of the MajesTEC 1. Therefore, I think we would expect a higher rate of infections with longer follow-up if patients stay on therapy. Notably, there were 3 deaths from infectious complications while on Teclistamab in both our study and the MajesTEC 1 study. So overall, I think Teclistamab appeared safe and relatively effective in a heavily pretreated myeloma population. While Teclistamab was associated with early responses, I think durability and deepening of these responses need to be determined with longer follow-up. I think that incidence of severe CRS and neurotoxicity seen in our study was low, and I think that raises the possibility of safely administering Teclistamab in an outpatient basis without necessitating hospital stay in the near future. Also, these data are encouraging for Teclistamab administration in the community by local oncologists, especially after the initial step-up dosing. However, it's essential to acknowledge that cytopenias and infections remain a challenge. So close monitoring and supportive care with antibiotics, IVIG, vaccinations, and growth factors are important for patients to mitigate the risk of non-relapse mortality.